pleasure for me to introduce for you Professor Mike. He is from England. He is a professor of internal medicine. No? Okay. Yes. He's a professor of nephrology, internal medicine, and he has special interest in diabetes.
It's our pleasure to introduce Professor Mick from United Kingdom. Professor Mick is going to speak to us about the challenges in glucose control and oral hypoglycemic agents in diabetic kidney disease. Professor Mick.
Thank you, chairpersons. I'm honored and humbled to be invited again to this wonderful congress. Thank you to the faculty and Professor Ines for asking me to come. I'm a nephrologist, and therefore I have a lot of problems controlling diabetes in my patients. I work with a diabetologist who says once the patients are referred to my clinic, he doesn't want to see them anymore. So I have to deal with all the problems and the challenges of looking after patients with diabetic kidney disease as they are progressing towards dialysis. So I'm just going to, you know most of the things I'm going to talk about today, but I'm just going to remind you how we define diabetic kidney disease, why it is important, and what are the options in selecting safe hypoglycemic agents strategy, and then what are the limitations of these medications as chronic kidney disease progresses, and what are we going to do in the future to address the problem. So as usual, we have to remind each other the epidemiology and the problems with diabetes. This is data from, this is the REACH registry, and this is an international observational study that's been done in many countries, 44 countries, registering round about 50,000 individuals with 3 or more cardiovascular cardiovascular events, peripheral vascular disease, coronary artery disease, and any other cardiovascular problems that they may face. And over a 4-year period, some of these patients were had diabetes, and you can see from this cartoon that those patients who had arthromatous conditions had the highest risk of further cardiovascular events over a 4-year period. I think. Okay. So you can see those with diabetes here had more problems compared to the other groups. This is overall incidence hazard risk for death, myocardial infarction, or stroke compared to those patients or those individuals who did not have any diabetes. So these are things that you already know. When you then bring it down to risk of death, you can see it was higher in the patients with diabetes. Hospitalization hazard odds ratio was 33% for hospitalization, and all-cause mortality, and you can see it was higher in the diabetic population. And as a nephrologist, this is data from the renal registry published in 2009, showing that those patients that had got to end-stage kidney disease, 24%, the majority had end-stage kidney disease due to diabetes compared to other causes of chronic kidney disease. So as a nephrologist, I'm very much interested in this topic. Now, in terms of definition, it's actually quite simple. So albumin-creatinine ratio of more than 2.5 milligrams per millimoles, and all eGFR of less than 60 mils per minute. And this is diabetic kidney disease, a clinical diagnosis, particularly in the absence of other kidney disease. And this will affect up to 40% of individuals with diabetes. In some populations, it's much higher than that. For instance, in the US and in some places, some areas in Asia. And there is usually a triad, long duration of diabetes, poor glycemic control, and the old terminology of diabetic nephropathy was if there was proteinuria of more than 3.3 grams over 24 hours. But now we got albumin creatinine ratio or protein creatinine ratio. So microalbuminuria is a marker of diabetic kidney disease. And usually there may be some family history. Majority of these patients who have hypertension, and there may be presence of other microvascular disease such as retinopathy, peripheral vascular disease, and impotence. Now, I remember last time I was talking about this topic, somebody asked me about biomarkers, and there's a vast number of biomarkers already in a search for the best one. And up to now, I don't think we've found one that is very reliable, but these are on the left side. They are picked up in the early onset of diabetic kidney disease in urine or in serum. And then in terms of identifying patients that will progress over time, these are the ones that have been suggested that there may be a possibility that once we identify these patients, they're likely to progress. But I think there's a lot of work to be done to be absolutely certain which one is reliably a good marker for early onset and a good marker for progression of diabetic kidney disease. But the most important point we've made here is that proteinuria is an early marker of diabetic kidney disease. It is also, as you know, a risk factor for progression and for other problems. And this is data that was published in Kidney International in 2011, showing the relationship in red of heavy proteinuria, so proteinuria of 0.3 grams or more, in blue, mild proteinuria, and then in green, moderate levels of proteinuria. And as you can see, if we take, for instance, this cartoon here, all-cause mortality, as the GFR drops over time, and so has the adjusted relative risk for all-cause mortality increases. The same is true for cardiovascular mortality, the same is true for end-stage renal disease, the same is true for acute kidney injury, and of course the same is true for progressive chronic kidney disease. So over the years, we've now come to an agreement, a consensus agreement in a lot of national and international guidelines that this is what we should be doing in terms of finding out which patients have chronic kidney disease. So stages 1 to 2, you want to identify them as early as possible, put in lifestyle modification, adjust the protein intake, and then treat all the risk factors to target. So HbA1c 7% or less, blood pressure 130 or 70, and then the ones that are progressing should be referred to the nephrologist, particularly the ones that have nephrotic syndrome, have hematuria, and eGFR is falling rapidly. Because some of these, of course, may have coexisting other renal disease. And then for stages, CKD stages to 3, the management is the same as CKD 1 to 3, but then we do other things like group education for the patients. We address bone mineral disease, we adjust phosphorus intake, salt intake, treat anemia, and so on and so on. And of course, others that progress further on, then we prepare them for renal replacement therapy. But the key thing is that we have here on this list established therapies, so blocking the renin-angiotensin system with ACE inhibitors or ARBs, blood pressure control, and of course glycemic control. And then there are other agents that are coming for glycemic control, and we'll talk about those in a few minutes. And then there's all these other therapeutic interventions that are really mostly research rather than established treatment. And everybody in this room is aware what glucose can do. And high glucose levels will eventually activate these biochemical pathways that lead to damage to the endothelium, to damage in various organs, and in particular for the kidneys, to development of diabetic kidney disease, as you can see from here. The interesting thing is that when we look at the landmark trials for glycemic control, we've only managed to reduce the incidence of diabetic kidney disease or the progression of diabetic kidney disease. But in terms of cardiovascular disease, then even the landmark studies haven't shown this, except for the old ones like the DCC and the UK PDS that you are all aware of from previous discussions. But of the recent one, which is the advanced study at the bottom, and you can see here a population of 11,000 type 2 diabetics, intensive therapy versus standard therapy over 5 years, and you can see HbA1c was down, and there was reduction in microalbuminuria, reduction in macroalbuminuria, reduction in patients going to end-stage kidney disease compared to standard glycemic control. But of course, in the ACCORD trial, this was not shown the same way. And in fact, if you look at all these large studies, you can see, in fact, that cardiovascular diseases did not reduce over time. So these are the tools that we have for oral therapy, and there are problems with chronic kidney disease when these patients do develop it. And a lot of these drugs, there is limitations in terms of as the CKD gets worse, you may get accumulation of the drugs and therefore predisposition to a lot of adverse side effects, and in some cases, progression of CKD. And this is a very busy slide, and I'll take you through it. And so in the dot that shows that's red, that means the agent is actually contraindicated. And the yellow, it means the drug, the dose of the agent should be reduced in this renal impairment. And then the green one, it means there's no need to adjust the dose even in the presence of end-stage kidney disease. And you can see here, for mild renal impairment, virtually all the drugs we can use. So this is stage 1 and 2 CKD. But as renal function gets worse, then there are problems with side effects. You can see more yellow dots come through. And then, of course, by the time we get into severe and end-stage kidney disease, then the majority of these agents you can't actually use. And the only one on this list with a green dot in end-stage kidney disease is in fact linagliptin. And you can see the bad guy here is actually metformin, or should be metformin, or is it metformin? So he's got, as soon as the renal function gets from mild to moderate, then the recommendations is that metformin should not be used. And the metformin story is well known to yourselves, and metformin originally extracted from this botanic compound called Galegia officinalis. And you can see actually metformin is absorbed and excreted in the kidneys unchanged. So it comes in the bowels, it's taken up by the liver, ends up to the kidney cells, and you can see it comes out here completely unchanged. So it means as kidney function gets worse, then you get accumulation of metformin. And of course, the biggest worry is that metformin, there's a risk of lactic acidosis. So before I talk more about metformin, I just wanted to show you this interesting observational study which was published again in Kidney International in 2012, looking at oral hypoglycemics and progression of kidney disease in these patients. And you can see, in fact, sulfonylureas over time, there is a risk of 10 to 20% reduction in kidney function over time compared to metformin. So I think metformin is not such a bad guy. So if you take the National Institute of Clinical Excellence guidelines from the UK, they said that avoid metformin when eGFR drops below 30 and use metformin with caution between 30 and 60, and if it goes below 30, then consider alternatives which are more renal friendly as listed here. And then if the function gets much worse, then you have to look at GLP-1s or insulins to be considered. But in the Cochrane study, which is again a meta-analysis that was published in 2011, they looked at 347 studies and showed that the incidence of fatal or non-fatal lactic acidosis was very low. In fact, only 4.3% on metformin compared to 5.4% patients not on metformin developed lactic acidosis. So now, what we do in our area is that we actually tend to use metformin with eGFR up to 30. And then we tell the patients that if there is an intercurrent illness, especially if there is a chance of fluid depletion when acute kidney injury may happen, then the patient must have their UNEs done. The dose of metformin is reduced to 2,000 per day if eGFR is between 45 and 60. And the other thing is to remember is that the eGFR you get from laboratories is based on the MDRD equation. And the MDRD equation does not take weight into consideration. And it's not valid if the body mass index is more than 35. And therefore, eGFR, if you have somebody who's obese and has type 2 diabetes and CKD, the eGFR you must calculate using the Cockcroft-Gault equation, which uses weight as a variable. And therefore, you might be able to actually use metformin in some patients where the MDRD suggests that they have renal impairment, but in fact, it's probably exaggerated. And when you do the Cockcroft-Gault equation calculation, you may find that eGFR is actually higher than it is when you do the MDRD calculation. But around the world, a lot of places use the cutoff of 30 mils per minute as a contraindication to the use of metformin. In Australia, Switzerland, they tend to go for anything eGFR below 60 per minute is a relative contraindication for the use of metformin. But more recently, I think the USA have relaxed on permission, the FDA permission for people to use metformin. They are now softening that we should be using it even the eGFR between 45 and 60 mils per minute. So this is data from our experience. We took our patients with type 2 diabetes from 2012 to 2016, and those with obesity with a BMI of 30. We then calculated the eGFR with MDRD equation, but then recalculated with Cockcroft-Gault equation. And anybody who had an eGFR over 30 mils per minute, we kept them on metformin. We also could use GLP-1s, and then we monitored their HbA1c, weight, how the renal function progressed over time, month 4, 8, 12, and 18. And just quickly take you through this. You can see at the top here that are actually glycemic, this is 27 patients on metformin. Glycemic control improved over time. Their weight, look at the weight reduction in those patients we kept on metformin as long as the eGFR was above 30 mils per minute. And you can see from MDRD equation, this was their EGFR. And then when we did Cockcroft-Gault calculations, you can see the EGFR was actually higher than MDRD. So we're able to use metformin in these patients over time. And then the ones that had GLP-1s was the same case. Their weight went down, glycemic control was better, and in fact their renal function did not deteriorate, and none of these patients developed lactic acidosis. In some cases, of course, you can't use metformin, in which case you may wish to consider other agents, but in terms of the DPP-4 inhibitors, there is also suggestions that we should adjust the dose according to the renal function. All of them, EGFR under 30 mL per minute, metformin is the agents are contraindicated, but you may be able to use them between 45 and 60 mL per minute. And at the bottom is just a list of the common side effects that have been found in the use of these agents. So, I think I have discussed with you this morning that diabetic kidney disease is common, is treatable, and is preventable, and that the actual strategy to have is for early identification, and this can be done by just measuring the protein in the urine. Glycemic control, of course, is very important. We've shown you some data to suggest that progression and development of diabetic kidney disease is reduced if we control diabetes, although that does not translate into cardiovascular risk factor or cardiovascular events reduction. And more importantly, in the clinics, those patients with high BMIs above 30, 35, please calculate the EGFR with Cockcroft-Gault equation, because you may find that the renal function is better than it shows with MDRD equation. Most, in fact, all oral hypoglycemic agents are contraindicated when EGFR below 30 mL per minute, except linagliptin and pioglitazone. Mr. Chairpersons, many thanks for your attention.
Thank you, Professor Mike, for this comprehensive talk. I have few comments. Number one, we cannot prevent the occurrence of complications by any means. All what we hope to treat the patient early, to decelerate these complications, not to prevent. We are trying to decelerate as much as we can the complications.
Sure.
But so, nobody on the earth can prevent complications in any disease. Okay. Deceleration only. This is number one.
Okay.
Yeah.
Yes, I agree. So if we talk about prevention, there's data to show if you block the renin-angiotensin system in hypertensive type 2 diabetics, they may not develop diabetic kidney disease.
Yes.
Yeah? We got data to show that. And we've also got data to show once you develop diabetic kidney disease in the early stages, you can actually stop progression.
Yes.
There is data to show.
Comment two, all of us, we know that microalbuminuria occurs in diabetes in very early stage of diabetes, very early.
Yeah.
And the extent of microalbuminuria is related to the complications, especially in kidneys, and to the complications also in other systems, especially the cardiovascular system. The extent of microalbuminuria from the start is related to the extent of the complications. Do you have any experience about the relation of the extent of microalbuminuria and hemoglobin A1C, H1C, HbA1c?
Yes. So there is a correlation between poor glycemic control, HbA1c. The higher it is, the higher the chances you may develop microalbuminuria. Yes. And you are absolutely right. The level of microalbuminuria, the level of proteinuria, is also a marker of the development risk for cardiovascular events and also for progression.
About lactic acidosis, it's not common.
No.
We see many acidotic diabetic patients, but actual lactic acidosis is not common. It is rare.
Yes, I think the Cochrane systemic review demonstrated this, that the risk is actually very small. And the risk is highest when the patients develop acute kidney injury. So metformin on its own does not cause acute kidney injury, but it's when you got acute kidney injury and you're on metformin that you may develop lactic acidosis. So the key thing is to inform the patients if there is any intercurrent illness, particularly if there's fluid depletion, that they may develop acute kidney injury, then they must have their UNEs done, or they must discontinue metformin until they've had UNEs done.
Lastly, what is your opinion when we meet a case of diabetic nephropathy? All of us give the patient insulin immediately. We are not resorting to give him oral hypoglycemic drug, but we prefer to give him insulin.
Yes, I'm aware that there are several, in fact, even in this room, that will start insulin early in patients with diabetic kidney disease. But that is quite an expensive strategy to adopt. And we know that we got enough oral hypoglycemic agents in mild and moderate kidney disease that we can use oral hypoglycemic agents to treat diabetes. So early start of insulin, I haven't come across data to show that's more superior than somebody who can control diabetes with oral hypoglycemic agents. But when you develop moderate to severe renal function, then the early start of insulin is better than oral hypoglycemic agents.
Thank you, Professor Mack,
Thank you.
for this very illustrative review about the history of metformin and the kidney disease.
Thank you.
I just want to ask if the metformin has some concerns. We don't say it is a very dangerous drug, but there is some concerns in its use in some situations, especially when there's acute kidney damage. And among diabetics, most of our diabetic patients use non-steroidal anti-inflammatory drugs as a way to treat their painful diabetic nephropathy. And these drugs are very well known to induce an acute kidney injury. So why to risk the patient and giving him metformin, even if he is not in the end-stage kidney disease? What is the benefit of taking this metformin in the presence of the vast variety of new oral anti-diabetic drugs, which may be more safer than metformin? What's the value the patient may got in using metformin specifically and not DB4 inhibitors, for example, or glitazones, for example?
Well, where I come from, cost is very important. I mean, we work in the National Health Service. It's free to the population, and therefore they encourage us to use the cheapest strategy you can give to the patients. And so if you're able to use metformin, there's no reason why you shouldn't. If you're not able to use metformin, then you can go to the more expensive agents. And there's no, linagliptin, for instance, there's no contraindication at any level renal function with linagliptin. But if you think about the cost, it's more expensive than metformin.